but they're very, very, very rarely ever taking the time to go in and clean all the ligament that still resides inside the bone. So in this situation, what I'm showing is the place where the ligament used to be, and I'm doing it in green because it's meant to represent infection. So this wisdom tooth that used to sit in this area was pulled, and the ligament was left down in the bone. What happens is the bone on this side of the ligament can't get on this side of the ligament. It's like a wall. Bone can build in our bodies, and it builds like this. One cell next to it, next to it, next to it. Builds one cell at a time. So when you have a ligament that's left down in that area, bone cannot fill in that space that the root of the tooth used to house. And what happens is we get bone grow over the top of the lesion so that from the outside or the inside of the mouth, there's pink gum tissue here and everything looks like it's healed. In reality, what we have with cavitation osteonecrosis is that we have an area left inside the jawbone that continues to house all of the anaerobic bacteria and toxins that resided in the tooth or the root canal. I put this root canal adjacent to this cavitation because, as a reminder, for me to be able to tell people what we find surgically, what we find clinically. Root canals are very infected teeth. And what happens is the infection associated with root canals starts to cause high acid levels in the bone, starts to cause the bone to decompose. And what happens is we routinely find that when we have a root canal on a second molar that sits next to a third molar, we are able to follow the infection from this tooth through the bone all the way back to this cavern. And it's important for you as the patient to understand, bone is not like a block of concrete. It's porous, and there's medullary spaces, and it's very easy for bacteria and infection to travel through bone. We are interested at Transcendental Health in these cavitations, not because we love to cut, and do surgery. We're interested in them because they house very, very, very toxic bacteria. I know this to be true because I've done the pathology research myself. We routinely send in samples of blood to Dental DNA in Colorado to examine the contents of these cavitations. What we find is almost indescribable. We find incredibly high levels of very toxic anaerobes. We find bacteria that we can't find anyplace else hardly on the planet. We find fungus, we find viruses, we find pieces of metals. It's almost like the body in its wisdom looks at these low blood supply, dead bone areas as places where it can store unhealthy things. So the toxicity associated with cavitations is very, very, very high. And we believe that in order for a patient to try to achieve and maintain optimal health, cavitation lesions need to be identified and treated. The purpose in trying to treat a cavitation is to get this area to refill in with bone. And again, there's different ways that people will try to approach this. We support protocols of the people in our time who've had the best results. We follow the Huggins protocol when it comes to cavitation surgery. With our surgery, basically what we're doing is we are accessing the bone through the gum tissue very close to where this cavitation lesion is. And then it doesn't take a whole lot of work after that. You can tell when you look at the bone, or if you barely put pressure on the bone caves in. It's like Indiana Jones or something. You're looking for a secret room and you just open a little door and there's a massive vault. That's what it's like when you see these cavitations. I've seen cavitations that were as big as my thumb. And you don't imagine being able to look inside a jaw that's filled with bone everywhere and finding a big space where there's no blood supply. There's nothing happening. It's just like an empty space of necrotic tissue. So we access these areas and we go in and we surgically curette or debride out the dead bone. As you do that, you start to get past where the infection is, back into healthy bone. And then you see the body start to bleed into the area. And it's a wonderful thing. And just like we do when we remove a root canal procedure, we sit and we observe and we honor and we get behind the body's wisdom in this process. We open that area and it bleeds and the body purges and the body purges. And then when the body decides that the purging is stopped, it starts to clot. And that's how we try to support the body. We suture these things up so nothing about that cavitation is exposed to the oral cavity. And we support people nutritionally and therapeutically through the process of healing.
And you see the cavitations, that means the hollow spaces in the jawbone. What can we find inside the jawbone? We found fatty, degenerative marrow and spongial bone. It's totally soft, it's yellow, it's fatty, degenerated.
And of course, what I didn't realize when I got into this that this was supposed to be a religious movement. You have to believe in Nico or not believe in Nico, and it's kind of silly because ischemic bone diseases have, in the past 30 years, come into their own. They're well established. They're responsible for a large amount of surgery and replacement of hips and knees. And our job version is just another variant of that whole thing. It's not the exotic, really different, unique disease that we originally thought it was going to be. Bone just happens to be particularly susceptible to a slowdown of blood flow through it. That and the brain, for different reasons, of course, are the two most susceptible tissues in the body to ischemic change. And of course, because this is in the jaw, we get a lot of secondary or sometimes primary inflammatory changes as well. But that's, nevertheless, the ischemic problem seems to be the major problem.
This is an extraction site of many years' duration. You all still see the lamina dura of the bicuspid and molar? That's not normal. Many of my colleagues and some of the oral surgeons that I've sent x-rays to for 30 years in my practice would tell me that that's normal. Here's underneath a ponic where you can see a radiolucency and some calcifications down in there. Radiolucencies in between teeth. Again, more of the lamina duras and a what they call a Jacob's ladder trabeculation pattern. This is one where they didn't make a flap. They just anesthetized, took the needle, and it fell right down into the hole. Look at the top of the alveolar ridge here. You can see that is not as hard and as dense as it should be. Here's one where they have a round area around radiolucency with some calcification. Another one similar. You can have lesions in the jawbone. You can have necrotic bone, fibrous marrow, which is one of the findings that we usually see. Some of these lesions, when you open up into them, as I said, are hollow. Some of them have a leathery consistency. Sometimes the bone is real soft and mushy. Sometimes it's fairly hard. But it's all abnormal in consistency. Here's the actual lesion itself. Look what has happened to the nerve. If the lesion is down in the area of the vascular bundle, it can become demyelinated. There also is a fistula tract that in this diagram is shown to bypass a vital tooth and go to the area in front of it.
The one thing I didn't get a good picture of before I did this was when we took it back, out here, you can see a red dot there. There were red dots all the way around. And all I did was cut and connect the red dots. That's really important when you're doing a lower, is connect the red dots. And you'll go through. Sometimes you sit there and go, oh my God, how deep is this going to go? It always goes into a void. The only thing that you have to realize, and this is why I did this picture, is look at how it faces buccally. The biggest mistake you're going to make clinically is you're going to go lingual and you're going to be into the tongue and the soft tissue. Error to the buccal. Go out to the buccal. Remember, do not exit on the lingual plate when entering the third molar area. A lot of people are going to be digging here. Look what's there. The tongue doesn't like a burr in it. And if you want to see that, we can show you some 3Ds. It's always to the buccal. And so we start cleaning that out and take a round burr. Clean it out so you can see it. Make sure you can't see through a wall, you can't see through bone. Make sure you can see the whole thing.
Background. Jawbone cavitations are hollow dead spaces in jawbone with dying or dead bone marrow. These areas are defined as fatty degenerative osteonecrosis of jawbone, or also called neuralgia inducing cavitational osteonecrosis, or NICO. They may produce facial pain, but they also have been linked with the immune system and chronic illnesses. Surgical debridement of jawbone cavitations is reported to lead to an improvement in immunological diseases and complaints such as rheumatic, allergic, and other inflammatory diseases. Little is known about the underlying cause and effect relationship. Objectives of the study. Jawbone cavitations, bone samples
were analyzed to assess the expression and quantification of immune modulators which can play a role in the pathogenesis of immunological diseases. The study supports a potential mechanism where jawbone cavitations are a mediating link in immunological diseases. Material and methods. Samples of fatty softened bone taken from jawbone cavitations have been extracted from 31 patients. The specimens were analyzed by bead-based multiplex technology and tested for 7 immune messengers. Results. Rantes, a chemokine, also called CCL5, and fibroblast growth factor 2 are found at high levels in the jawbone cavitations tested. Other cytokines could not be detected at exceeding levels. Discussion. The study confirms that jawbone cavitation is able to produce inflammatory messengers, primarily Rantes, secondary FGF2, the fibroblast growth factor. Both are implicated in many serious illnesses. The exceeding levels of Rantes and FGF2 in jawbone cavitation patients with amyotrophic lateral sclerosis, multiple sclerosis, rheumatic arthritis, and breast cancer are compared to levels published in medical journals. Levels detected in jawbone cavitations are higher than in serum and cerebrospinal fluid of MS and or ALS patients, and 4-fold higher than in breast cancer tissue. Conclusion. The study suggests that jawbone cavitations might serve as a fundamental cause of immunological diseases through Rantes and FGF2 that they produce. Thus, jawbone cavitations and implicated immune messengers give an integrative aspect of immunological diseases and serve as a possible cause. Removing jawbone cavitations may be a key to reversing immunological diseases. There is the need to raise awareness of jawbone cavitations throughout medicine and dentistry. Thank you for your attention.
Most people and most dentists think that once the troublesome tooth has been extracted, the problem is solved. But for many, this is definitely not the case. In order to explain why, you first need to understand a little about how the teeth attach to the jaws and the normal processes of healing. Most people are surprised to see how big the roots of teeth are, but like trees, there is as much below the surface as above, because they have been designed to withstand heavy function for a lifetime. The outer plate of the jaws is composed of smooth, compact bone, but within it contains cancellous or trabecular bone, which looks like a sponge. The junction between the teeth and bone is unique within the body. It is a modified ligament with fibres which pass from the condensed inner bony surface surrounding the tooth roots into the cementum, which is a relatively soft, thin, calcified layer which covers the surface of the roots of the teeth. When the tooth is extracted, much of the periodontal ligament is usually left in situ, and this can then present a barrier to the intended healing mechanisms. Ideally, the periodontal ligament and any infected bone should also be removed at the time of extraction. This would result in the formation of a blood clot in the socket, and various immature cells are then able to migrate into and develop within this medium to become blood vessels, bone and gum. This is known as healing by primary intention and is the ideal way to heal. The first type of problem that can occur with healing after an extraction is that there may be either insufficient initial bleeding to obtain a blood clot in the extracted tooth socket, or the patient may subsequently have dislodged the blood clot. In the case of an inadequate blood clot forming, many think that the use of local anaesthetics containing substances known as vasoconstrictors, which restrict the blood supply to the area, may be at least partially responsible. However, there may also be compromised circulation generally or locally, which may relate to an underlying health condition. If no blood clot forms or it is lost, then a so-called dry or infected socket will ensue. Here the exposed bone of the tooth socket becomes packed with bacteria and food from the mouth, and even the abrasive agents used in toothpaste. This sets up a localized bone infection, which is known as osteomyelitis, and parts of the exposed bone die in a kind of osteonecrosis. A dry or infected socket can typically be very painful and may also smell or taste bad, and the person may feel generally unwell, have a temperature and possibly some swelling. The dentist will usually clean the area out, insert a soothing pack, and may prescribe antibiotics. Eventually the socket will at least appear to heal, but in this case it heals by what is known as secondary intention, whereby the socket has to slowly fill in from the sides and the base, and this can result in very slow healing. This may also be associated with sloughing portions of dead bone, which may continue to appear for some months after the extraction, and which many patients may mistake for being fragments of tooth. These may be shed naturally or may require removal by the dentist. The other problem that can occur is that the vast majority of dentists do not clean out the periodontal membrane after a tooth extraction because they do not recognize and are not taught the importance of this procedure. This means that not only can the remaining periodontal ligament act as a barrier to the ingress of the immature cells required for proper healing, but also that the ligament can become necrotic and act as a breeding ground for bacteria. The mouth is one of the most densely populated places on Earth, containing over 6 billion microbes belonging to over 600 different species. Most cavitation infections appear to be mixed, and biopsies have shown the presence of up to 30 different bacterial species. The normal bacterial flora of the mouth, when introduced deep within the bone of the extracted tooth socket, can then mutate into anaerobic forms. These can cause tissue decomposition and necrosis, which can spread internally within the bone as a kind of gangrene or osteomyelitis. In response to the infection, white blood cells enter the affected area, and in their attempt to destroy the pathogens, also create destruction of the bone. Some of these immune lymphocyte cells can also mutate, developing multiple nuclei. The pus that forms can then spread via the blood vessels, and this further impairs the blood flow, which causes areas of devitalized bone to be sequestered and create chronic infection. This process leads to the development of what is known as a cavitation, or hole within the bone. The problem is that the socket usually apparently heals, with the gum growing over the extraction site and a thin layer of bone forming. The normal signs of infection, such as redness, swelling, pain, or a running temperature, may also all be absent, so that not only are the lesions hidden from view, but there is often no overt sign that there is a problem. And, although infection plays a role in the development of cavitations, many feel that the problem is essentially caused by poor circulation to the area. This results in both a lack of the nutrients and oxygen required for healing, and also in compromised removal of toxins from the region. Cavitations can also spread through and around adjacent structures, such as adjacent teeth, blood vessels, nerves, veins, and other extraction sites. They can also continue to grow to become quite large, with one dentist reporting a cavitation 6 centimeters long. Cavitations can be responsible for subsequent hyperesthesia, that is, areas that are highly sensitive, and also for areas of the mouth that are difficult to anesthetize. In addition to extractions, root canal treatments are also recognized to introduce bacteria deep within the bone, as the canals within the teeth are instrumented and cleaned. And this procedure may also cause a localized osteomyelitis or osteonecrosis around the tips of the roots of the teeth. There are two main issues with cavitations. The first is that they can act as a so-called focus of infection. This means that the toxins they produce and the microorganisms they harbour can enter the circulation and affect distant body parts. Focal infection theory was popular in the late 19th and early 20th centuries, and other suspects included the tonsils, sinuses, the appendix and other organs including the gallbladder and kidneys. Proponents enthusiastically removed body parts and extracted teeth, and the large number of teeth extracted in the 1920s, combined with research in the 1930s casting doubt on the approach, led to it falling from favour. However, natural health practitioners and holistic dentists feel that there is a lot of merit in the focus of infection theory, and even mainstream academia is now tentatively re-examining the issue, having possibly thrown the proverbial baby out with the bathwater. The toxins that cavitations produce may also account for subsequent chronic pain, including neuralgia and headaches, and for chronic disorders such as sinusitis, arthritis, fibromyalgia, back pain, multiple sclerosis, and amyotrophic lateral sclerosis. Specialist practitioners treating cavitations report cures of disparate conditions including blindness, autoimmune disease, tinnitus, fibromyalgia, and the disappearance of cancerous tumours. The second big issue with cavitations is that they can adversely affect the energy meridians that flow through the teeth and jaws. Although subtle, these are very real and animate the life force of the individual, serving different organs and systems. There are 12 paired energy meridians, and many pass through individual teeth and the jaws. The energy system is a two-way process, so that an underlying weakness in an energy meridian may account for why poor healing occurred after an extraction, or even why the tooth decayed in the first place. Equally, the presence of a cavitation or any other pathology on the meridian pathway can cause poor function of the affected organs or systems served by the meridian. For example, the development of a cavitation after extraction of a wisdom tooth may adversely affect the heart, small intestine, and hormone production, and cavitations forming further to extraction of the first or second molar teeth may cause problems with the large intestine or lung. Some specialist practitioners estimate that 80 to 90% of routine extractions may result in the formation of cavitations, and the further back in the mouth the extraction, the more likely they are to occur. Researchers estimate that this problem may affect half the population, with the majority of those affected having multiple cavitation lesions. Of all the teeth, lower wisdom teeth most commonly form cavitations. This may be because the area was often necrotic and infected prior to extraction, and also because the bone in this region is particularly dense. However, because of their obscurity and the lack of practitioner familiarity with cavitations, these holes in the jawbone routinely evade detection. Sufferers may frequently have failed to respond to conventional and even alternative treatments, and this effect will not be eliminated until the cause is identified and adequately treated. Cavitations are notoriously difficult to detect using the usual methods such as examination or X-rays. Visually, the gum has healed and there may be no overt signs of redness or swelling over the extraction site. When it comes to X-ray detection of cavitations, the signs are either absent or subtle and easily missed. This is because a change in bone density will not be apparent on X-ray until there is at least 30% loss of bone. With proper healing, the outline of the condensed bone surrounding the roots of the extracted tooth should have disappeared within 2 years of the extraction. If a faint outline can still be detected on X-ray after this time, this may indicate the presence of cavitation. There may also be a subtle change of bone texture or signs of destruction of the compact bones surrounding the inferior dental nerve in the lower jaw. Although scanning using a CAT or MRI scan can reveal cavitations, it is expensive, exposes the individual to significant radiation, and is usually interpreted by a radiologist who is probably not especially familiar with the concept of cavitations and who may miss the signs. The most reliable method of detecting jaw cavitations involves the use of a device known as a cavitat, which uses an ultrasonic scan combined with computer software to produce a three-dimensional image of the jawbone. Relatively few dental practitioners own and operate these devices, but the manufacturer maintains a list of dentists who do. In addition to cavitations and soft spots, It can also detect areas of hypercalcification, which may also indicate an issue with healing. The US Food and Drug Administration has recently approved the Cavitat as an adjunct device to determine low bone density in desiccated bone. In order to receive the stamp of approval from the FDA, the company submitted 4,000 case studies, and the device demonstrated a success rate in excess of 94% in detecting problem areas. Other means of detection include electrodermal screening to measure energy flows through the energy meridians, and the more low-tech method of using kinesiological muscle testing to localize problems in the mouth relating to energy flows. When it comes to treatment, anything short of surgical removal of the dead bone, periodontal ligament, and infected area is destined to fail. This surgery creates a clean field and a blood clot into which bone cells can regenerate, producing healing. While dentists dealing with this issue report quite high cure rates, there is also a strong tendency for the cavitations to recur later. This may be because of underlying problems with poor oxygenation of the area, and some advise the use of hyperbaric oxygen before and after surgery to increase oxygen levels in the tissues. Some think that part of the problem may relate to the type of local anaesthetic and injection that dentists routinely employ. Anaesthetics typically contain a vasoconstrictor such as adrenaline, also known as epinephrine, and this serves to retain the anaesthetic in the region long enough to be effective and also to prevent hemorrhage during surgery or extraction. However, this constriction of the blood vessels may ultimately contribute to creating both dry sockets and cavitations. Certain regions are more vulnerable to bone infection and necrosis due to the particulars of their blood supply, and the lower jaw or mandible is one of these regions. Whereas the upper jaw is fairly porous and has an extensive blood supply because it is part of the skull, the lower jaw or mandible is a separate movable bone with just one artery that enters either side of the jaw near the joint. This means that teeth in the upper jaw can be anaesthetized by means of an anesthetic deposited locally, known as an infiltration injection. But in the lower jaw, a block injection is typically used, whereby the anesthetic is deposited adjacent to the main arterial and nerve supply where it enters the jawbone. This may compromise the initial formation of a blood clot in the first few hours, causing more problems after lower tooth extractions. Other factors that predispose towards poor healing include the use of medications including corticosteroids such as prednisolone or dexamethasone, biphosphonate drugs which are used to treat osteoporosis and some cancers, and the use of estrogen-based drugs such as the contraceptive pill or HRT. Underlying medical conditions such as diabetes mellitus, cancer, and more rare conditions such as Paget's disease of the bone or Cushing's syndrome, which is excessive production of cortisol by the adrenal glands, are also implicated. In addition, pregnancy, alcohol abuse, smoking, radiotherapy treatment, and poor oral hygiene are all thought to be contributory factors to the formation of cavitations. Mercury from dental amalgam fillings has also been shown in studies to accumulate within the jawbone, and in particular to collect around the ends of the roots of the teeth that have amalgam cores underlying bridges or crowns made of gold or porcelain fused to metal. The presence of mercury in this vulnerable area may kill the bone cells by starving them of oxygen, and being a heavy metal, mercury literally settles in the base of each body compartment, concentrating in the lower jaw. Nutritional deficiencies may also be a factor in poor healing, and it is possible that all of us are effectively deficient, since our native diet is estimated to have contained 10 times the minerals and vitamins of our modern diet. The division of the body into parts, rather than viewing it as a cohesive whole, is never more apparent than when it comes to the division between dentistry and medicine. Typically, dentists have concerned themselves almost exclusively with care of the mouth and teeth, and ignore or cannot see the implications of their treatments on general health. And doctors regard the mouth as the province of dentists and show little interest in its health or restorative status. This means that important causative links are being overlooked daily by dentists and doctors all over the globe, and that much preventable suffering ensues as a consequence. Although cavitations were first described by G.V. Black, the father of modern dentistry, nearly 200 years ago, and have been recognised by physicians and dentists since as a cause of systemic health problems. Mainstream dentistry, including the American Dental Association, currently refuses to accept that they exist. Until something becomes accepted dental school teaching, it will, in effect, not exist for the vast majority of dentists. So if you suffer from chronic health problems that could date back to a tooth extraction, and particularly if you recall having an infected or dry socket, or the extraction was of wisdom tooth, it might be worth exploring the possibility that some of your problems may relate to this overlooked but serious cause. However, be warned that your dentist may not even be aware of the problem, and you may need to seek out a specialist dental practitioner. Also, be aware that if you require an extraction, a little prevention can go a long way by seeking out someone knowledgeable about this issue.